What? Hello. We're here. Look, sound effects.
We made it.
Hey, girl. How's it going, James with a J?
I'm good, Mama. How are you?
I'm great. Hello, my sweet titillations. It's me, the one and only Mama Tits, coming at you live from the Tits and Tea podcast with my with a J. We are here for episode 6. That's
already 6.
Girl, episode 6.
Time flies when you're having fun.
Girl, well, it's only episode 5 for you, but episode 6 for me, because somebody decided to take a time off. But it's kind of crazy. So just to let everybody know,
I'm going to travel.
Well, this is true, and we're both going to be traveling in the next couple weeks. We've got that'll be the Cameron Michaels episodes, because next week we've got Jackie Beat. On the show, and then the week after we have Cameron Michaels, and that's the week that you will be in Alaska and I will be in the Poconos, so we'll be coming from remote locations, so that'll be fun.
Yeah, it'll be different.
Yeah, I'm excited for it. How have you been? What's been going on?
Not a whole heck of a lot. Girl, had a real fun time last weekend. I got to dance to DJ RuPaul.
Okay, I saw that she was coming to Seattle.
Yeah, Seattle's outdoor Occidental Square Park. It was a beautiful night, good vibes, good energy, and all around good time. I danced my butt off.
I love that. I love that. Well, honey, that's the way it should be. That's the way. Anything wild and crazy happened while you were there?
Not while I was there, but unfortunately afterwards there were a few shots fired in the area, city living, but I don't think anyone was injured or anything.
Well, that's good. But yeah, and people say, oh, what's it like living in Mexico? How do you feel safe? I don't have to deal with that.
Nothing like that has ever happened anywhere near me when I've been in Mexico.
No, yeah, it's kind of wild. But you said you had an encounter. I remember you telling me something about how
that's right. I keep forgetting about that.
Yeah.
I ran into this really, really sweet gal.
Okay.
She was dancing in front of us where we were standing, and we chit-chatted throughout the night. She was super sweet, and ran into her again at the end of the night, and somehow it came up that we were doing a podcast. I think maybe my friend Jeff mentioned something about the podcast, and she was like, oh, which one? And I was like, oh, it's called Tits and Tea. And she stopped, and her eyes got really big, and she's like, wait a minute, I listened to that. And in the moment, my brain kind of shut down. I was like, this can't be real.
Right.
We've only done a handful of episodes. There's no way that anybody's gonna recognize little old me, but she was super excited, bouncing around, and it was sweet. It was great. It felt amazing.
That makes me super, super happy. That makes me super, super happy. Because that means that people are out there watching what we're doing, seeing what we're doing, interacting with what we're doing. And so I love that. So
I hope she's listening again today.
I hope she is too. But hey, come on. Welcome to the world of being recognized. I love it. We just kick off this new thing, and all of a sudden you're getting, oh my God, you're on the Tits and Tea podcast.
Right.
Oh my goodness. So normally every week we bring, hot topics, chisme, hot seat, and all of that. But today we're actually doing something a little bit different. Today we're going to be talking about sex. Let's talk about sex, baby. Let's talk about you and me. Let's talk about all the good things and the bad things that may be. Let's talk about sex. Let's talk about every little thing about it. Let's talk about sex. Let's talk about sex. So for this, sorry, I don't know why I did that entire stanza, but we decided to do something a little bit different this time. And since we were having fun with Michael Schmidt last week, we did a little out of the formula last week. I was like, you know what? Let's throw in something fun, because we're going to go back to some drag queens here soon. We're going to have a couple of that fun stuff, because we'll go back and forth. But I want to bring somebody on that both of us have known for quite a long time.
Yeah,
and
I used to swim with his husband on the Seattle gay swim team. I've known these guys for years. Yeah,
I love that. And I've known these boys, especially through PV, but in Seattle and through PV. And over the years, we've gotten to know each other. And his name is Dr. Dan, and he's really, really amazing. And for those of you who've been following along on my cancer journey, he is the doctor that helped me when I was looking for prescriptions in the United States. We did everything, of course, up and all legal, but he was the one who stepped up and helped. So I want to go ahead and bring him on so we can start talking about stuff. I see he just popped on. He actually was on call tonight, unfortunately, so he had to pop away, but he's already waiting for us in the green room. I see him sitting there. So I would like to bring on both of our friend, Dr. Dan O'Neill. He is Chief Medical Officer at San Francisco Community Health Center, specializing in HIV and LGBTQ plus care, addiction medicine, and street medicine. So please welcome Dr. Dan. How's it going, Dr. Dan?
Hello. James. How y'all doing?
We are doing wonderful.
Yeah, I just got off that call. I hope she doesn't have to vamp too long, but I'm glad there was a green room for me to wait in for a bit. So
yeah, no worries. I figured it'd be smooth and easy and no worries.
And happy you're here.
You know, and if you do end up having to do anything, you are a doctor, so I get it. We get it.
Yeah, it happens, but I figure I was like, okay, perfect timing. I got to step away for a moment, but. That's in the clinic I'm in right now. We're in the Tenderloin, and so people. I think just last week someone overdosed in the bathroom, and so we're running codes quite often. Sadly, still in the fentanyl epidemic, and really, the Tenderloin's at the epicenter of that. So every day is exciting and different and challenging, but so I'm used to it. It's okay.
But I'm glad you're doing the work. I'm glad we have people like you in the community doing the work. And, you've had a good, strong path in HIV, LGBTQ plus care. And tell me, out of every specialty in medicine, why HIV, why LGBTQ plus health, and why street medicine? Like, why are these like really close to your heart? What drew you into all that?
Yeah, I'm a type 1 diabetic. I was diagnosed at 14. And so I thought naturally that's what I would get into. And earlier on, I was interested. And I was lobbying for embryonic stem cell research. That was the George W. Bush's first 2 vetoes. And that brought me to DC. And when I was there, I lived as a wayward young gay behind Whitman Walker Clinic, which is the big LGBT center in DC, and started volunteering there and very much fell into that. Became part of the gay LGBT community there, and realized there were a lot of parallels between diabetes and HIV. Found the stigma and treat the disease, that you could have a long, normal, healthy life and not have an otherwise horror show of things go wrong at the end. Yeah. But it's needed to support people in terms of HIV adhering to their medications. Also in diabetes, in terms of adhering to diet and medications and managing all the things. So I felt that parallel, and HIV was so impacting the community that I was part of. And there's special people along the way. One man in particular, Peter Fox, who was beloved in DC and helped make my early connections to early mentors. And I was like, I'm here in DC. This is part of my community. And from the public health angle and otherwise, HIV really naturally fit my passion. I'll also say that HIV, kind of the silver lining about it is it's forced to the surface all of the issues that society and that all of us have to face that we don't want to talk about. Addiction, poverty, all the social inequities out there.
Access to medical care.
Sex, yes. Harm reduction, all of those kind of bleeding edge, interesting, challenging questions that will never not be interesting and will be difficult. And so I thought that made sense for me for a life and career. And I love the work I do. Is challenging, but as challenging, particularly in these times, it is important work, and I get a lot from it and from helping patients. Yeah.
Let's touch on that real quick. You and I both revolve, around healthcare areas. And there's been a lot of restrictions on so-called gender-affirming care, recently, and that has really affected the services that may be offered to folks from certain, medical institutions, but also, the cost and effects and after effects of that kind of care. What have been some of the challenges of navigating these restrictions in this time and still trying to provide quality care to people in the community who need it?
Yeah, that's a great question, James. And what my clinic does and encounters on the daily is in this world of increasingly scarce resources. And under this administration, where we have lost multi-million dollar, multi-year grants that were just stripped away under the early executive orders. This was back in February of 2024, right? They really didn't waste any time of demonizing trans and gender diverse people. And the way and the speed in which it has happened is just beyond what anything that we could have anticipated. I mean, I knew it was going to be bad, but when people's jobs in the clinic rely on this. Services, most importantly, are patients. This is people with food insecurity who are trans, and trans and gender diverse folks are certainly disproportionately impacted, in terms of being able to find a stable job and income and housing. And so, understandably, that results in challenges around access to healthcare in particular. And so we have struggled in having to pivot and find new creative ways. There are new opportunities that we've really taken a hold of in California, that enhanced care management is a way all those case management services helping with those health disparities that I just described, that we can finance that don't rely on a lot of these grants. And I'm on meetings after meetings of all the LGBT organizations behind the scenes strategizing, not just about all these support services, but then hormone therapy and how do you pay for the labs. And there's a variety of different models from within a federally qualified health center having to carve out gender affirming care. So it's set up as another line of business or a whole separate 501c3. There's a lot of different strategies that we've really had to roll our sleeves and explore. We, where I am, get a little bit of reprieve because it's really folks doing pediatric gender affirming care that have been hit hard and early.
Well, it's so unfair.
It
is so unfair to see this attack on gender affirming care when, gender affirming care is such a broad spectrum of things, and it is something that as humans that we need, and it doesn't need to be locked into somebody's ideal of what it has to fit into this box. Gender affirming care is that spectrum. It is that, whatever is needed for the individual. And it's really horrific to watch all of this happening. I can only imagine what it's like on the front lines for you, but to watch this happen to our community and to see this ripped apart, and it's so disproportionately affecting trans and especially trans people of color. And it's not fair. It's not just, it's not right. It's not smart. It's cruel. And it's, to me, it's, I look at our trans siblings as these beautiful anomalies that come out, and they get to show us that it's not so cookie cutter. They get to remind us that, we are human beings, and we are, if you want to believe that we are part of that ethereal, that universal energy, and we are, we can express ourselves in so many different ways. And, as three queer men, some of us may present more masculine, some may present more feminine. I like to kind of play between both masculine and feminine.
Yeah.
I feel very comfortable in that. And, you know, gender affirming care is something is like access to shavers or, moisturizers.
There's so
And
much that cis people do that's gender affirming care. And
yeah, and they're just
not,
villainizing
but
this
also I
because
must underscore that gender affirming care is life saving. And I think for the average person, they don't see what I see. I mean, I saw 5 trans patients today, and it's all about how do I line up the surgeries in what order and how can we, there's a sense of urgency and fear that it's all going to go away.
yeah,
And, if I could share so many stories
it just
about
breaks my
how
heart.
dysphoric and suicidal, and I
Ugh.
think the general public thinks it's just something, cosmetic. Are they really appreciate and cannot have the empathy to somehow, it's because it's too foreign to some people, and if they just got to know trans people, as
Well,
they,
that's the thing is
so I said,
where
if all gay people just came out, similarly, if everyone could just get to know a trans person and
yeah.
feel lived experience and how life-saving.
I mean, what does that say about where we are as a society? What does that say about where we are as a society, especially because as a whole, they are villainizing, one of the most smallest group
Yes.
in all of this. And it's just heartbreaking.
Well, and since we've got Dan here, let's take a moment. There's so much fear mongering, when talking about trans and gender affirming care. What can we dispel, especially about what gender affirming care looks like for an adolescent, or a younger person?
Because everybody's afraid that it's just like, oh, we're handing out, sex reassignment surgeries, and we're, giving breasts, and we're giving hormones to kids and doing this and that. And I know that's not happening.
Yeah.
If you want to turn to the evidence, which people
Please
don't do, right? Right, is that far and away gender affirming surgeries, there is little to no regret. Is there a possibility? Well, not certainly to the degree that any other plastic surgery that cis people all day long, every day, all the time, and other broader surgeries for various reasons. I mean, it is a deliberate, thoughtful process. Like I said,
correct.
I had a conversation with a colleague the other day of, we're talking about the timing around a surgery, and in medicine, we talk about something being like necessary, like it's urgent, so you forego, the precautions to emergently get this done. And that in so many ways, I even found myself that could be postponed to this, and it's life-saving. I mean, we have to do it thoughtful, and when someone is medically optimized to do it, but
well, and also
not just being handed out. Yes.
No, of course not.
And it's not like someone just walks in and they get their surgery the next day. It's quite a long and multi-step process, right? Like someone has to be truly committed to go through all the steps. It's not just a whim.
So to walk you through the process, right? So I did this several times today. We've orchestrated this whole referral communication with surgeons. Patients, we need to set up housing. So if you have a vaginoplasty or facial feminization or surgeries that require, you have to do dilations for a period of time after. If I've got one of my patients that lives in a homeless shelter that's in a congregate setting where they don't have their own bathroom, you've got to set up housing so that following have that. They need to have appropriate nutrition in order to heal and reduce risk of infection and etc. And a lot of patients have that food insecurity, so we've got to set up that. So many pieces have to come into play. The surgeons require that they've quit smoking and that they have all these labs done, and so many things have to be lined up that it is unnecessary in a lot of sense, in a large sense, all the hoops that we have to jump through, where with other surgeries, it's often not as rigorous. And it's that gatekeeping that's always been a problem in the past. And the trans community has worked to really pull back all of that, such that trans folks have informed consent, just like any other surgery or procedure that's done. People, and if they have the capacity to make that decision, why all the extra barriers?
Why is it anybody's business? Why is it anybody's business? You know,
when it comes to
if it's an adult,
then,
if it's an adult and they're going with stay out of it. And youth, and when it comes to the youth situation, you know, there are people who are fear mongering and saying that all of this is happening to the youth, and that's just not happening.
Yes.
Like, you know, I do know that there are some children that do have gender affirming surgeries if they were born, say, intersexed, and they needed to, you know, say for whatever reason. I've heard of people having things changed because it was medically necessary, and that's a different thing. But it's like they're not doling out, you know, sex reassignment surgeries to children. That's not a thing. They're not, you know, but what are they doing for children?
Initially for children, it's they're one of the first steps is going to be preventing puberty, which is incredibly traumatic, and it's to experience that or appreciate the trans experience is not set goalposts that we define for the patients. It's like when they come in as, what's your gender with journey? Where your journey with gender? Where do you want to go? And some folks who are trans feminine, you know, assigned male at birth, but may not want to go and have a phalloplasty. Someone who's trans feminine, male at birth, and then wants to become or is moving towards their affirmed female gender. May not want surgeries. They may, I have some trans masked guys that want to have a testosterone level that is kind of in between, deliberately in an androgynous zone.
Interesting.
Right? And so appreciating that it's not the binary, that
it's not.
We have many non-binary folks and people without genders. And I learn from my patients every day. I misgender and put my foot in my mouth, as all of us do. And that's one of the questions when interviewing new staff is, when you misgender or have misgendered someone, how do you respond to it? Or if you hear someone else misgender, and it's just appreciating the seriousness around that. And I'm fortunate to live in places how the world should be, where almost half the staff at San Francisco Community Health Center. We also have a trans homeless shelter and this fabulous, it's called Trans Thrive. You should check it out. It's a community center that's run entirely by trans folk that provides all kinds of case management services. We have
amazing
clinic there a couple of nights a week. But I get to work, and you have to ask people's pronouns, and we'll make mistakes, but you correct and move on, right? It's just part of the culture, and it shows me of how the world really should be. I mean, that we're not so wrapped up in what gender, who cares? I mean, who cares? Right?
Really, it is whatever you tell me you identify as. Cool. That's your identifier.
The need to project gender on someone else is just, we must.
I find it strange. I find it weird. I find it it's, I don't know, it's almost that brainwashing, that heteronormative binary style, you know, and I like being a part of the kind of the radical faggot group that is really kind of pushing back on all of that. You know, and
I don't think this gets talked about enough, but the amount of misogyny steeped in trans discrimination. Right, like the discussion and the debate is always about male to female, right? Like with the whole trans and sports debate, all of these laws focus on female athletes. You know, none of the discourse involves female to male trans. It's all misogyny. It's all
very
in the fear of the feminine. And I think it's so obvious, but it does not get talked about enough.
Yeah, and I mean, at the end of the day, you know, not to be flippant, but who cares? I mean,
yeah,
like, oh my
but that's
gosh,
true. Who cares? Like, why do you give a shit so much?
It's because it's been used to deliberately as this issue, right? To demonize and scapegoat, and it's so, you take a step back and it's so obvious what's happening here, right? And the rancor and hate. I mean, we've gotten hate calls ever since Trump. And by the way, I have to say, I am not speaking on the behalf of San Francisco Community Health Center. These are all my own opinions. Just I meant
completely. I don't want. Yeah, please, anybody out there listening or anything, that whenever we have a guest on, especially like Dr. Dan, he is not here to give you medical advice or anything. If you have anything that you feel you need a doctor for, please search within your community for a medically licensed doctor and clinic, and go have a conversation and speak to.
I am a doctor, but not your doctor.
Exactly.
So,
exactly.
It does come to medical advice too. Thanks.
And come on, this is a damn podcast hosted by a goddamn drag queen and a homosexual called James with a J. I mean, come on. If you're coming here for medical advice, but okay, so
you'd be surprised.
it's very true. So good girl. That part.
The number of penises with rashes I have on my phones from friends, you would, yes, Well, I'm happy to, but there's limits, right? And then
you're like, hey, you should go. Oh my God, why are you sending me this photo? You should go see a doctor. You are a doctor. I'm telling you, go see a doctor. As a doctor, I'm telling you to go see a doctor. Oh my God. Yeah, no. And that's funny. It's always funny to me when people do that to doctor friends. I mean, you and I have spoken over the years, and I've talked about different things, and you've never given me any medical advice because you're not my doctor, but you've always given me guidance and ideas and like, hey, I need to navigate this, I need to navigate that. And another part of what you do, aside from, being such a warrior within the medical community and helping out our trans siblings, is something that is also really close to me, and that's also dealing with HIV and HIV prevention and those of us living with HIV. I myself am a survivor of HIV. I've been a survivor for now over 25 years. I'm undetectable. I'm very, very happy and very healthy. And I want to get into some of the discussion about HIV and stigma and undetectable, what that means. I do want to talk about, PrEP and doxy-PEP and all of that, because here, especially here in Puerto Vallarta, we are such a very sex positive community. I know you in San Francisco, Dr. Dan, you were just at Folsom. You go to Doreali, it's very sex positive there. Seattle is very sex positive as well, a little bit more underground, but a little bit
Folsom's coming up, Mama. You got to get the calendar right. Dory happened, but
wow. Okay.
It all blurs together.
Okay, my goodness. Okay, just.
Some angry gay is going to be coming for you.
Exactly.
And to your point, Mama, the farther you get from these cities, these metropolitan areas, the harder it is to find this information, right? Or find
which is why I want to talk about stuff like that here, so that those people who are listening from wherever they're listening, they can maybe get some help. Because I know for me as a survivor of HIV, stigma's been a big thing. A lot of, living here in Mexico, there's been an education barrier with a lot of different people. Good thing in the queer community, we are getting more information out there, but it's just an uneducation situation where the undetectable status, people are still very afraid of HIV. People it's really interesting because I don't hear the word AIDS thrown around a lot anymore. And what the difference is between the two. People don't realize that there is actually a difference between the two. One is a more advanced version of the other, and all of this. And I want to break down some of this stuff with people and talk about PrEP and the fears that maybe people have, and some things that maybe are misconceptions. I'd like to disperse or, I can't think of a word right now, lack of hormones, brain fog. No. But thank you. Dispel some of these things. So talk to me, Dr. Dan, about, first of all, what does it mean when someone is undetectable with HIV? What does that mean?
Yeah, great question. And actually, I just listened to a lovely podcast about this, and some top scientists discussing undetectable. So undetectable is really the lower level, the lowest level at which a virus can be detected in the name. And that lower limit has progressively, as the tests have gotten more and more sensitive, has gone down over the years. I mean, when I first started my training 10 to 15 years ago, like less than 70 or something was considered undetectable. But there are other flavors to it as well. I mean, what I care about is getting the virus down to a level where it's not going to potentially generate resistance.
Correct.
I mean, really less than 1,000 to 500, or like that is in a range where you're probably not going to be transmitting it to other people.
Okay,
right?
that's
So,
really
like,
good information, though.
yeah,
A lot of people don't understand
what
that.
you'll hear and what I get scared patients say is, oh, it's now, our test today, less than 20 copies per mil is generally, that's copies of virus, is below that is considered undetectable. Now suddenly they get something that says detectable, or maybe even still less than 20, or detectable at 30 or 40.
Yep.
And these blips, as the term is called, can happen from time to time. It randomly depends on where and how many virus just happen to be in that sample, and there's going to be variability.
I mean, I had my normal numbers. One of my last times when I did my numbers, I had a blip. I had it where, I'd been under 40 replications, for a long time. And now it's down to 20 replications, where for me it was 40, 70 was one, under 100 replications that, was kind of when I began, it was like under 100, 150 where you're doing good. They've got it pretty controlled. And I had it, I was down in like, 20s and 30s, but then it kind of blipped up to like 50. And I kind of panicked a little bit. And my doctor was like, no, you're still undetectable.
Yeah, and I forget that how frightening sometimes that can be.
Yeah.
And the explanation that's needed. Your drug has not failed, right?
Nope.
I'll still ask the question around, how's the adherence been? I mean, if they're on a long-acting injectable, I know how their adherence has been, but it will ask other questions. It all depends on the context in which that test
and
is.
Me, I had just happened to change medication in the last 6 months. And it's one of those things where, sometimes your body just reacts a little differently and everything's fine.
Or it's the limitation of the test itself, right? There will always sometimes be issues with tests. There's variability. And generally, I talk about this in primary care all the time. The pre-test probability when going into run a test, whether it's a lab test or a physical exam maneuver or an imaging study, people think that we can just indiscriminately do tests and see whether it's positive or negative. It doesn't work that way. It might seem that way from the outside looking in, but there's a false positive and false negative rate, and wide variation in how something could be interpreted. And so when this is why we don't do body scans, because if you just body scan, you will find something that's not really clinically meaningful, right? That now you've caused psychological harm to the patient. Now we have to do a cascade of all these tests because some little nodule in the adrenal gland or the lung appeared, and the patient says, "What is that? It's cancer." And now we have to follow it. And whereas otherwise they would have gone their entire life.
Yeah.
It would have. It's the equivalent of a skin tag, but inside their body, right? And so tests, just doing them indiscriminately, cause harm. Now, to make it real to what you were talking about, the doctor's going to want to know if you just changed, and there would be a reason for that potential blip. Right? Or if you switch now from oral to a long-acting injectable, or
which unfortunately we don't have access to here in Mexico. But
yes, and I've just come to appreciate that as at Doreali recently, when we're distributing DoxyPep and providing information on PrEP, a lot of the international folks have come through, and yes, they don't have long-acting injectables.
No, and that's one of the things that I wish we had more of.
Yeah. That's been a real game changer. So about a third of our patients are unhoused here in the Tenderloin, and we collected some data that showed in the past year, over half of them, their belongings and tent and everything was swept away by the city, right?
So then what do you do with
Half of
medications?
them,
Yeah.
yes, and we can think this, but this was real data, and they said half
Yeah.
of their medications were swept away, and only 10% of those got those meds back. So
Wow.
injectables, now you don't have to worry about that your prep was swept away, or that your HIV medication, which you need to keep your virus suppressed, isn't swept away as well. So this is kind of a new era, and there's some inertia, and it takes time to transition to these new things. But now we've got a number of years under our belt, starting with cabotegravir. The brand name's Apretude, which was
How long are these long-term injectables for?
Like 3 months.
Yeah. So, well, Apretude. Apretude also, there is a Cabenuva is the HIV treatment, and that combines two injectable drugs, cabotegravir and rilpivirine. And you do a baseline injection, and then you do it again a month later. That is your loading dose. And then from there on, it's every 2 months, plus or minus a week window, right? For PrEP, to prevent HIV, you just get one of those two drugs, cabotegravir. This is an intramuscular injection in the butt. If you've ever had syphilis or gonorrhea and you got your injection there.
Or if you've ever lived in Mexico and you have an infection or anything, and that's how they stab you all the time with the antibiotics here for everything. Yeah.
That's what it is. And then again with the Apretude at baseline, a month later to load, and then every 2 months thereafter.
Do you think they're ever going to get one to be like 6 months or a year?
They're already there, Mama.
What?
Yeah, as of a year ago, in June of last year, they approved lenacapavir, or Yeztugo. Now, lenacapavir is a new class drug that had been introduced in years prior as part of salvage therapy. So if your HIV treatment and your resistance to so many things, and you just need something new and different to layer on top, you could add lenacapavir. That's an injection every 6 months. And this has been a real game changer for a lot of our patients who couldn't tolerate Apretude for whatever reason. This is, Apretude is about, 3 milliliters of an injection. So about, 2 digits of my, once in intramuscularly into the buttock. So Capavir, though, is 2 smaller injections about the tip of my finger, so 1.5 centimeters, and it can either go in the abdomen, just under the skin here.
And
it's kind of like a chickpea size injection, and then it dissipates with time.
I know about those. I know about that chickpea. Because with my cancer treatments, they give me the castration medication where they shut off my testosterone, and it's in a 12 gauge needle, and they stab it in my stomach, and it dissolves over 3 months. And this October, when I go get my next injection, they are changing me to a 6-month blocker.
Oh, there you go.
The one thing I will tell people, if you're getting that injection with those little bead little things, have them put the Novocaine in first, because when that needle goes in, I screamed bloody murder the first time, and oh my word, that it's a piercing needle. It's I mean, they're huge.
With Apretude and these that are prepared, you can't have like lidocaine with them. But I would recommend, if you're getting like a ceftriaxone injection for gonorrhea, ask your doctor if it can be kind of reconstituted with some lidocaine, so it won't be as painful. Syphilis, clearly you can't mix it with lidocaine, but to your point, that can kind of numb things up and make it easier. But just to finish about the Yeztugo, it can go here or in your thighs. Like if you're a ripped gay dude and are fearful that there's going to be little nodules there because there's not much fat, you may go in the thigh. But I would say it's also subcutaneous. And I know this as a diabetic doing subcutaneous injections for the past 30 years or so. They can be more painful, I feel, than an intramuscular injection, because all your nerve endings are right there at the surface. And so some folks said they prefer just the one Apretude, even though it's more frequent, then the every 6 months, and it's every 6 months, then plus or minus 2 weeks. So you get a month on either
Oh,
side. It's a
interesting.
big window. The Yes2Go, when you start it off, because there's no loading dose like with the Apretude, and it takes some time for it to get up to those levels, they give you 2 big tabs, oral lenacapavir, that you
Ooh.
take the day you get the shots, and then the next day, and then they say probably a couple of hours after that, you may be protected against
Wow.
B. And that's those oral tabs day of and day after really kind of get your levels up to where you're protected. So you don't need another shot anytime soon, but rather every 6 months.
Now,
Oh,
and
wow.
we were talking about like also people taking, because people are taking PrEP, so they can not have to worry about, contracting HIV. And then there's also DoxyPep. And, and we've had some interesting, some people take it, they get, once every 3 days. Some people are told to take a DoxyPep pill, every time they have a sexual encounter. What is the kind of situation, and what does it mean to be taking that all the time?
Yeah, so all great questions. So to take a step back, DoxyPep, what it is for one. So the way it's to be prescribed is it's doxycycline, which is a common antibiotic that has activity against not anything to do with HIV or any viruses.
Correct.
But the common bacterial infections, chlamydia, gonorrhea, and syphilis. Now, importantly, the evidence shows that it's pretty good for chlamydia and syphilis, not so great for gonorrhea. The relative risk reduction there is less than 50%. So still some, but it's probably closer 80 to 90, around 87% for syphilis, chlamydia. In terms of the relative risk reduction, that is to say, if you have someone with those infections and you have sex with them, what's the likelihood it's going to prevent that from happening? It is not treating an already active infection. So could asymptomatically be infected with gonorrhea, chlamydia, and just taking it here and there is not, even though chlamydia now, the recommended treatment in the US is that if you are positive for chlamydia in any of the 3 sites, pharynx or throat, urethra or urine or rectum, that you will take 1 tab of doxycycline twice daily for a week.
Okay.
It's to be that we just did 1,000 milligrams of azithromycin once and done, but there's too much resistance for chlamydia. So you actually
that's good to know, though, that a lot of people need to know that there's that the azithromycin isn't the one pill and done anymore.
I mean, it can and still has some active, but it's there's so much resistance, it's not likely going to be as effective.
Okay.
But the point being is doxycycline. That's the same medication you're taking as DoxyPep. Doxycycline also has activity against gonorrhea, but we would never treat it with doxycycline and syphilis. If you don't have penicillin injections available, penicillin G or bicillin, then there are longer regimens that you can, for different stages of syphilis, that you treat for different lengths with doxycycline. So the point is, it's got activity against all of these. And the idea behind DoxyPep is you're taking it within a short time frame after the exposure, and nipping it in the bud, so an infection never takes hold.
Okay.
Right. So real quickly, there's PrEP, pre-exposure prophylaxis.
Correct.
Prophylaxis is to guard or protect against, and so you're taking something before the exposure, and that's the HIV drug that you're taking daily or before you're ever having sex, and then
correct.
Because I hear these terms interchanged. I want my doxy prep. It's not doxy.
No.
It's PrEP. It's post or after you've had sex.
Post-exposure prophylactic and pre-exposure prophylactic.
Yeah, and so
there are two. It's a 2-step system that helps.
Yes.
And so guard against different things.
So well, PrEP and PEP are just medical terms of am I doing this thing before or after?
Correct.
Right. So then with DoxyPep, you take 2 of the doxycycline together. it's better the sooner you take it. So I say try within 24 hours, but up to 72 hours.
Okay.
Right? Now, we talked about PEP, and like I said, PEP is a medical term. So you can also have HIV PEP, right?
Yes.
Is post-exposure prophylaxis. Similarly, you have a 72-hour window. This was developed from medical providers who pricked their fingers with a needle to draw blood from someone with HIV. We found it's very effective. You take a full HIV regimen, like what you would be on Mama, but not. I don't know what your particular regimen is, but you would take that for 28 days or a month, right, to prevent.
Yeah, I'm on a Dovato, one pill once a day.
Yes, of that. Right. So this would be one tab once a day for a month. Or there's some regimens that's multiple tabs once a day for a month. But that idea is similar. That's HIV post-exposure prophylaxis. You are exposed, but you got to get in.
Yeah, you got to get in quick before that thing.
72 hours. So that was the idea. Yeah.
Yeah. Let me ask you this.
But wait, before we go over there, James, to finish that though, there are people that are taking PEP, Doxy PEP, every day.
That was my question. Are there any drawbacks, consequences of that?
Yeah, so let's talk about like potential side effects. And so I do have some patients that are sex workers that do take it daily. And you just need to not take it more than 2 tabs in a 24-hour period. So this is not if you have sex multiple times a day, 2 tabs every time you have sex, right? So if it's Friday and you have sex with someone, you may or may not take it. Again, the sooner the better. But then Saturday comes along and you have sex with someone, and then Sunday you could take 2 tabs of doxycycline together. Again, it's not separated 1 tab twice a day like if you're treating chlamydia, but 2 tabs together, and that could retroactively treat you for Friday, Saturday, and Sunday. Alternatively, you could take it on Friday, Saturday, and Sunday. Now, we know there's for acne and other things, doxycycline is an antibiotic. We all want to be good stewards of antibiotics and not have to, make it rain doxy. And there are potential implications for that. And I can talk about that in a sec. But some of my patients may take a doxycycline once a day to help control their acne. So there is a precedent of taking,
I didn't know that.
Yeah, longitudinally already. And it can affect your gut flora. The bacteria may give you diarrhea, other things. Doxycycline can, like antibiotic, cause a rash, and it can increase your sensitivity to the sun. So particularly at these events when we're giving it around and there's lots of sunshine or at Pride, then people need to know. With any antibiotic, you can have any slew of adverse reactions, from anaphylaxis, that's a very extreme allergic reaction, to a less common fixed drug reaction where you might have a rash or blistering that always kind of comes and goes in the same, it's very curious, but not the same spot.
Interesting.
You take it, right? There isn't an alternative yet for doxycycline if you do have any of those adverse reactions, and of course follow up with your doctor if you do.
Well, and of course, with every single one of these things, everyone should be speaking to their care provider and talking to their care provider and getting information directly from your doctor. Remember, Dr. Dan is a doctor. He is not your doctor.
Yeah.
Not asking about doxycycline itself, but in general, I've heard talk about building immunity to antibiotics over time. Is there any chance that taking doxy, over a long period of time, that the effectiveness could change, or that,
the way I would think about it is it's with respect to the bugs we're trying to treat, right? And gonorrhea already is indicating increased resistance. An important caveat with because of what I said, it's only less than 50% of the time is it effective with gonorrhea, which is not that big. People think that this is
the one all the
I can take. Oh, you told me that your test came back positive. Oh, I'm okay. I took my DoxyPep. No. Right. If
well, and that's the thing. We need to make sure that people are knowing that these are not these pills are part of a regimen, part of your sexual health, part of taking responsibility of being an adult and partaking in adult activities. And you need to know your status. You need to go take the exams regularly. Every 3 months, you should be in the clinic, just doing your regular test, just your checkups.
If you had a big orgy or more, like,
Yeah.
Like,
Just
no
go
doctors are
for
going to
it.
say, nope, I'm sorry, too early. We're
Yeah,
not going to test.
Yeah,
No.
and that's the thing is, I think we need to worry about the stigma that comes with that, because people are like, oh, I got to go to the clinic. No, girl, go to the clinic. Go to the clinic and get checked, because then you can come back and have fun. Because if you're not okay, then we can make you okay. And if you don't go to the clinic, then you're not going to be okay. You're not going to be able to be okay.
I don't want to downplay that, particularly trans people, but that queer people in general have had bad experience. That's the number one question I get, is where can I find a gay doc? And the Gay and Lesbian Medical Association, GLAMA.org.
Come on, GLAMA.
GLMA. They're in a lawsuit against Trump as well, actually. And but GLAMA does have a provider directory in your area. I should be on there too, but you look and you can drill down by what your insurance is.
That's a great resource.
Who's in the area, what do they specialize in, etc. Otherwise, it's kind of word of mouth and where, but I do
that's very true.
If you can find a queer doc, that's great, because we've all experienced that stigma. But when a patient comes in and they're nervous, your doc needs to know what they have, what body parts, where they've been. I mean, the question on his face is, where do I swab? Did a penis go in there? There are fingers or toys and like different.
Well, and the doc and hopefully, if they can find themselves a queer doctor or a good medical provider, the medical provider is not there to judge you. They just need to get the information.
They shouldn't be, because otherwise, it's like, try me. I've heard it all.
I can only imagine some of the things
I know people don't have similar experiences, but I chuckle sometimes when someone's nervous. But I've heard it all, and particularly queer docs are generally good. But we all learn, and like with trans patients, they teach me every day. Oh, I don't know about that, and you want.
But that's what we need in medical providers.
Curiosity, and I think if doctors always or clinicians of any kind took that approach, tell me about that, and we weren't as fearful of not knowing something. And patients, I love when I'm able to come in as a patient and teach my provider something, right? Yeah. Because then they're appreciative, but it needs to be that more back and forth, because we always want to learn and hear a different perspective. And so if you are a queer patient who knows, share with your doctor your experience. Don't be aghast necessarily that they don't know. They can still help you. Now, they should know something, and maybe they're not the right fit for you, but use that as an experience, because they want to learn. They should.
Well, and hopefully people are getting a good relationship with their medical provider, even if it isn't a queer doctor. Hopefully people are able to find some medical provider that they have a good connection with, that they feel that they can talk to, that they know that they can have confidence and they can share. Because if you cannot share with your medical provider what is really happening, they cannot help you. But I do want to say, just like you said, there are a lot of queer people, trans people that are in communities that are not safe for them. And is GLAMDA? Yes, is GLAMDA directory?
GLAMA.
The GLAMA directory.
Medical, but it's more expansive than just gay. And that's just a quick resource.
But at least, there are resources out there. Check out GLAMA, check out what's in your area, because we want to make sure that, especially our queer community, straight people,
your gay provider friends, we all kind of have a short little Rolodex. And
and that's the thing, is like, the straight people have everywhere they can go. They have all their own people, but our people, especially right now, we need to look out for one another, and we need to make sure that we have that network available. One of the things I wanted to, we are running out of time. I hate to do this, but we are having such a really good conversation. I do want to also talk about something before we go, since we were talking about HIV, we were talking about PrEP, we were talking about DoxyPEP, and we're talking about undetectable. I want you to explain to me what that means when somebody says that they are undetectable, and that means it's untransmittable. So because there's still a lot of stigma out there. Even though some people may be taking PrEP, they can still be very vigilante about, I need extra layer, or this or that. And I want to dispel some of those stigmas. I'm not here to say that if you want to wear, 42 condoms and that's how you feel comfortable with it, then that's fine. I'm not here to shame you with that, but I want to dispel some of those concerns, because for example, like my boyfriend is HIV negative. He is on his own cycle. He does his PrEP. He takes care of himself sexually. We take tests, but I am positive but undetectable. We do have unprotected sex because it is better. He has a latex allergy and that sort of thing, and I'm not able to transmit it to him. Of course, now that I post prostate surgery, I'm not able to actually ejaculate. So, that's kind of pulled things back. I mean, there are still seminal fluid things that do come out, but the good thing is that I cannot transmit it to him. And some people don't even realize that that's still an option. I mean, I knew when I became positive, I thought I'm never going to have sex again. It was never going to be the same again, or that, there's going to be all this stigma. And I dealt with a lot of stigmas. And now, when my HIV doctor came to me many years ago and said, you've been undetectable for over 2 years and you are very adherent to your medication. I see your blood work. I see everything. You don't have to live in that bubble anymore. So explain some of that to people so they can kind of understand it.
Yeah, U equals U has been around for a while now. And at first, there is that question of, can I have condomless sex with someone who's HIV positive? And we tested different fluids and different levels of HIV in semen versus blood and what this all means. And the evidence is now clear. There's been an avalanche, though we were all a little bit reticent to say that you're not going to transmit HIV sexually if you're undetectable, right? And I even would go so far as to say is you having sex with people who are presumptively on PrEP, right? Or you figure, they're taking their PrEP. Yeah, yes, is more risky when it comes to risk of transmission of HIV than someone who is HIV positive and undetectable. And I think it's important that because it's inescapable. I've had partners in the past who have been HIV positive. This was even pre-PrEP, and you just couldn't get it out of your head. And it's still difficult and challenging to have condomless sex with someone who's HIV positive. And that is that stigma that we need to break free from, because the evidence, which is what we need to drive our decisions. And it's your prerogative, as you said, if you want to wear condoms, if you want to make sure that you've got your PrEP on board, you're double, triple protected, right? Great. But it's to know at baseline that if you're having sex with someone who in and of themselves is HIV positive but undetectable, they're just not going to transmit HIV to you. So I think that is an important message to get out, and that has been so important for folks living with HIV and thriving, right? Because it has freed them of these shackles of like, how do I navigate this world where now
when I first tested positive, when I first tested positive, I thought everything was over. I mean, and it was a long, we did some looking, and I'd been positive since approximately the late 90s. It was when, after I'd had my doctor and everything, we looked back at it and he was like, you've been positive for quite a while, and it's just been kind of growing and doing its thing. And unfortunately, when we caught it, I was right before an AIDS diagnosis. I was about 50 replications away from an AIDS diagnosis, which is advanced HIV. And but we got on medication. It responded immediately, and I've been undetectable ever since. I'm 100% adherent to my medication. Back in the day, you had to be 90% adherent, and I've been 99 to 100% adherent for the last 20 some years. And it's been it's such a miracle to see that now, because growing up and seeing the lost generation die, and now to be able to be a survivor of HIV and to look at it and know that it's not going to kill you. it is manageable. We've got you, and now we can go to with undetectable means untransmittable, with PrEP, with doxypep. Like, we've got all of these different layers of things now which I think is such a beautiful blessing. And now we get to, hopefully, we get to start celebrating, especially a queer, sexual revolution, and realizing that, and dropping these stigmas and dropping the shame of being who we are and how we make love and how we love one another and how we share our love physically and how we can do that healthily, how we can do it, mindfully, and just make sure that we take care of one another. I just thank you so much for being here, Dr. Dan.
Yeah.
Yeah.
We would love to have you back again. There's so much to talk about.
Yeah, through it all. But
no, we didn't get through any.
And if anyone's got questions, I'm always happy. Yeah, I love giving medical advice. It's always with that caveat, but I wasn't meaning it to sound like I don't want people to reach out, but
no, but of course, you're doing this because you care, and you, of course, with the Litigious Society of the United States, you have to be very careful, and you have licenses, and you have to be careful of that. And of course, I know everybody knows that you are an amazing human being and wonderful and kind and there to help the community. And I know that if you're in the area in San Francisco and you are looking for and you need some services, go check out the clinic, and they will take care of you. And you might even see Dr. Dan out there. But thank you so much. We will have you back regularly. I'd love to have you back on a regular thing where we can get into some deep conversations about this, because I want to make sure that we're talking about sexual health out there with everybody, and stigma reduction and everything. So thank you so much, Dr. Dan. I love you. I adore you. You're amazing.
It was so good to see you.
And say hello to your wonderful husband for us, and you boys have a wonderful rest of your evening.
We'll be out to see you in November.
Ooh, we've got a brand new show. It's called Sweet Release.
Oh,
it's got a live band. Oh yeah, we're having fun. So speaking of all this naughtiness, Sweet Release is coming. So thank you so much. I'm gonna pull you off the stage, and you can either hang out backstage and we'll chat in a minute, or you can head out. But thank you for being a part of the show today, Dr. Dan. We appreciate you so much. Oh my goodness.
That was good.
What a great episode. I think that was really wonderful. We got to wrap it up. We're just 2 minutes over. We got to close it down and get it over. And thank you everybody for listening. Thank you, James with a J, for being here. You had some great questions. Next week we're going to be chatting with Jackie Beat next week.
Hey.
Yeah, I'm really excited. This is one of my favorite drag entertainers. I'm going to throw on a face next week. I think I'm going to throw on a face next week because Jackie Beat's going to be here. So, and for those of you listening, thank you for being a part of the Tits and Tea podcast. Check it out wherever you can download this episode, wherever you get your podcasts. We go live every Thursday at 6 p.m. Pacific, 9 p.m. Eastern on Instagram and on our YouTube channel. And you can watch our past episodes on YouTube or stream them anywhere you get your podcasts. We love you all. Have a good time. We'll see you next time.
Bye.